And the first speaker, Martina Carlsen Misic from Örebro University, you will begin and you will present two presentations too. So welcome on scene.
Thank you very much. I would like to begin with thanking the scientific committee for the opportunity to present two of my projects here today. I'm very honored to do so. And I will talk a little bit more about parents as pain management in Swedish neonatal care, SWEpap. And we know by today's theme that infants in neonatal care undergo many painful procedures. And despite the extensive research, infants still does not always receive efficient pain relief during these procedures. And as Mats mentioned before, parents are a valuable resource in the neonatal pain management. And there are several parent-delivered pain management methods that is efficient for pain treatment. And the aim of this study was to investigate parents and nurses' perceptions of and reflections on experiencing combined parent-delivered pain management. And this study was conducted in 3 Swedish neonatal units, and the participants were 9 parents with infants admitted to the units. There were 4 healthcare professionals, 3 nurses, and 1 assistant nurse. And we also invited 2 veteran parents, whose infants had been previously admitted to the neonatal care. And this study applies a collaborative participatory action research design with ethnographic-inspired data collection. So the data collection involved 3 parts. So in the first step, the parents, nurses, the veteran parents, and researchers met in focus groups. And the focus groups were performed virtually through Zoom meetings. And in these focus groups, there was the first part of the focus groups, which included knowledge sharing about parent-delivered pain management. And it was followed by a discussion in the group afterwards. And after these focus groups, the parents and the nurses and researchers together tested intervention. And in this study, the combined parent-delivered pain management consisted of skin-to-skin contact, live parental lullaby singing, and breastfeeding if applicable. And since these were preterm born infants, it was only one of the infants who were breastfeeding during the testing. And during the testing, we used this timeline with a 10-minute preparation time where the skin-to-skin contact began, and also the live parental lullaby singing. And the live parental lullaby singing you saw in the movie that Mats showed. It was a really calm and repetitive lullaby that the parents sang. And we also video recorded the testing of the procedure. And after the testing of the procedure, yes, and I would need to tell you that the painful procedure in this study was a planned blood sample or immunization. And after the testing, the researcher and the participants watched the video recordings together in a simulated recall interview situation. So, the findings. The preparation was considered a key for combined parent-delivered pain management, and both parents and nurses emphasized the importance of allowing time for the parent-infant dyades to calm down together before the procedure, as we heard earlier today, that the preparations are really important. And the combined parent-delivered pain management was considered feasible by both parents and the nurses. And the parents helped parents expressed that the singing helped them to focus on their infant instead of the procedure, that they were more intuitive to their infant signals, and they almost forgot what the nurses were doing during the procedure. And the live parental lullaby singing also created this calm and trusting atmosphere in the room. As we discussed before lunch, it affected not only the parents and infants, but also the nurses felt calmer, and that the parents had the focus on something else than what they were doing during the procedure. And after the procedure, both parents and nurses felt that they have successfully supported the infant through a painful procedure. And we didn't do any pain assessment in this study. It was just the participants' feelings about this intervention. And I will also like to quickly mention the part 2 of the SWEpap project. It's a randomized controlled trial where we will investigate the efficacy of the combined parental-level pain management compared to standard care during routine blood sample in healthy newborn infants. And we are right now analyzing data. And here's a picture of me and Alexandra Ullsten during early data collection. And Alexandra Ullsten is also the leader of the SWEpap project. Thank you so much for listening.
Yeah, thank you very much. Are there any questions in the audience about this? As we wait for those, I would like to ask you, what about the parents who are not included in this study? Have they asked for this too?
Yes, I believe so. I believe if you walk in like this open bay area in the neonatal care, you will hear parents sing for the infants. And I have been experienced similar situations to this study without doing it, where parents have wanted to do this by not knowing this even. So.
Yeah. Interesting.
Yes.
It spreads. Yeah. Any question?
I have a question. Thank you very much for your presentation. Yeah. My name is Kirsti, and I'm a music therapy down here in Skåne. And I've been looking forward to hear more about the SWEpap and the results. But just to make sure that I didn't misunderstand, so the SWEpap part 1, is that on full-term babies, or is it in?
No, it's in preterm infants, but it's just a qualitative study.
Okay.
So the randomized controlled trial will be on full-term infants. So this part was a preterm.
Yeah. Okay. So the video was full-term?
No.
Okay.
It was a preterm.
It was? Okay. That's very interesting. I'm looking forward to get some. Well, we also apply music therapy here during painful procedures. I work in Malmö 1 day a week and then 1 day a week in Lund. But what we often do is that the music therapy will be there humming, and then the parent will provide parental. Parentheses, just talking slowly, carefully with their child. So it's actually, I'm kind of being supportive in, I'm kind of supporting the parent and the child diet, because I sometimes think that we are demanding a lot of the family, that they should be humming. I prefer humming with the neonates compared to singing. For the children, sometimes they get, they're already quite afraid, or so the holding of the family system, and then they can next term hold their children. But what we really need is to get more humming and into this system of the neonatal care, because that's like a very fundamental human aspect, and we do sing lullabies in all parts of the world. So it's about time we get that back, and I think with your project, this is really adding something very important, and I'm looking forward to, to inviting you down and getting your help.
Thank you very much.
Thank you.
Yes, and I emphasized, I also think it is important that singing is not maybe for all parents at all situations, and maybe not all infants want to hear singing during painful procedures. So I think this could be another tool in the toolbox for the one who it suits the best.
I would also like to include that the more of the staff. The staff
Yes.
can be humming. I mean, humming is activating the parasympathetic nervous system. So, yeah, and maybe differ humming and singing compared to the child's age.
Yes.
Yeah. Well, great job.
Thank you.
Yeah, thank you very much. Is there any more question? I believe we are behind schedule already, and you have one more presentation,
Yes.
and we will listen to that. Please go on.
Yes, thank you. My second project here today, Clonodine as analgesia during retinopathy of prematurity screening in preterm infants. ROP screening is a painful and stressful procedure for the infants. And the eye examination includes restraining, bright light and a dilated pupil, eye drops that are painful to administer, manipulation of the eye, and the use of eyelid speculum. And there have been several studies investigating both pharmacological and non-pharmacological interventions, but there seem to be no fully efficient treatment yet. And a little bit more about Clonodine. Elisabeth has already told us before today. And Clonodine is an alpha-2 agonist that is used increasingly in the Swedish neonatal care due to its safe sedating and pain-revealing properties without the risk of respiratory depression. And the use of Clonodine can also reduce the need for other sedation and pain-relieving medications. So the aim of this study is to investigate the pain-revealing effect of Clonodine during ROP eye examinations. And this is a multicenter randomized controlled clinical trial with a crossover design. And infants born before gestation week 30 and therefore undergoing ROP screening will be eligible. And we will recruit infants from 2 neonatal units. And the units use different examination techniques. Unit A uses indirect ophthalmoscopy, and Unit B uses the RETCAM. And we did a power calculation that gave a sample size of 18 infants, and we plan to include 25 due to handling technical errors and so on. So there will be 25 infants at each unit included. We have some exclusion criteria. Infants who have received pain-revealing analgesic sedatives or beta blockers within 24 hours before the eye examination. Previously documented renal failure. Infants without nasogastric tube. Infants with known heart arrhythmia or neurological impairments. Infants with circulatory instability, and we define that by a mean blood pressure below the infant's gestational age at the time. So the infant's first 2 eye examinations are included in the study, and during the first eye examination, the infant will be randomized to either Clonodine, 4 micrograms per kilo, or sterile water in the equivalent dose 60 minutes before the eye examination. And the order of the treatment is blinded for everyone except the nurse preparing the study solution. And during the second eye examination, the infant will receive the study solution that he and she did not receive during the first examination. And our outcomes in this study. The primary outcome is pain assessment with the premature infant pain profile revised. So the infant's face and monitor showing oxygen saturation and heart rate will be video recorded to assess the pain afterwards. And the secondary outcome is galvanic skin response, where 3 probes are attached to the infant's foot sole to register changes in the sweat gland activity in response to painful and stressful stimuli. And the eye clinician performing the eye examination will also rate how easy it was to examine the infant. And since this is a clinical trial, we will also report adverse events, severe adverse events, and sudden unexpected serious adverse reactions to the Swedish Medical Products Agency. And this is an ongoing study, so unfortunately I don't have any data to share with you. At the moment we have included 19 infants at one of the units, and we are hoping for we're hoping to start up the other unit soon. And if you want to read more about our study, we have published a protocol study in BMJ Open. Thank you for listening.
Yeah, thank you very much. Oh, that's a question.
Thank you very much.
Thank you.
Have you standardized the involvement of parents, or the way the child is investigated? Is it in parents' lab or in the bed? And yeah, you
Yes.
understand what I mean.
Yes, I mean, and I noticed myself that I didn't mention it in the presentation. We haven't standardized. We use the standard of the unit, so the parents are involved, holding their infants and so, and we write that down in the CRF, so that we know some infants have been held by the parents and some don't. So it depends on if the parents want to participate or not. Yes.
That was a very important question in mine as well. And there is another question up there. Please, go ahead.
Thank you. I really appreciate this study, because this is a highly distressing moment for children, and I don't know so far of any strategy that is successful. But why clonidine? You say clonidine for a painful procedure. Clonidine is not pain-killing. Dexmedetomidine doesn't take pain away. It creates a kind of natural sleep status. So why clonidine? That's my first question. My second question is, you will assess heart rate as one of the indicators, but clonidine takes the heart rate down, so it will be lower in your group versus placebo. And the final one, I would just want to add to, so I have 3 questions actually, sorry for that. The final one is, why not standardizing the non-pharmacological setting completely, even if the parents do not agree? Because in clonidine, as it causes natural sleep, you see that if patients are held very comfortably, that's the effect of your clonidine, and not the drug on its own. So can you comment, please?
Yes, tough questions. I look at my supervisor. We use clonidine for other procedures in the neonatal setting, so that's why we wonder if it can be used during eye examination as well. I think it does have some pain-revealing properties, but I'm not. I'm honest to say I'm not fully into that. And as for the PIP-R scale, we measure the heart rate for that one. I'm trying to find a good answer. So we're measuring it due to pain assessment, so we will have to take that in concern, I believe, when we're doing the pain assessment, how the clonidine could have affected that, I guess.
Yeah, please.
So I just wanted to make a comment that clonidine does have analgesic properties because it's the alpha-2 adrenergic receptor, which is a presynaptic receptor. When there is receptor agonist binding, it activates the G2 alpha protein. So the GI2 alpha protein is the inhibitory G protein, which downregulates adenyl cyclase and therefore reduces cyclic AMP and therefore reduces the neuronal excitability and the action potential duration and things like that. So it has direct analgesic properties, but the same G protein is activated by opiate receptors as well. So when it's combined with any opiates, those effects are synergistic. It's the signal transduction of the alpha-2 adrenergic receptor and the opiate receptor is pretty much down the same pathway.
Thank you.
Yeah, thank you very much, Martina. We now know that you will have a system running for testing various drugs and various behaviors as well.
Yes.
Thank you very much for opening our eyes. Now we will proceed to the next speaker, Dr. Bindu George from Sidra Medicine, Qatar. Welcome on to the scene.
So good afternoon, everyone. First of all, thank you to the committee for accepting our abstract and for giving us this opportunity to present our work. So my presentation today is on the multiple quality initiatives which were done in our level 4 multicultural unit in Qatar that were focused at enhancing parental staff communication and parental participation in caregiving. Now, before I proceed, I just want to say I have no disclosures to make, and I want to take a moment to acknowledge and thank each and every one of the co-authors for their hard work and dedication to this piece of work. And they're all my fellow colleagues from the NICU at Sidra Medicine, and they're also a wide representation of multidisciplinary team members. So I'll also, over the next few slides, give you a brief background and also introduce our NICU and the challenges we met, which led us to do this quality initiative project. And as a background, we all know the core concepts of infant and family-centered developmental care. In this particular QI project, we were focusing on parent participation and parent-infant interaction. So we also know the huge benefits which come with parental participation in caregiving. However, in our unit, what we came across was consistently conveying the importance of parents being at the bedside and communicating the importance of parental participation and the benefits was not being done consistently, and not adequately all the information was being conveyed to parents. So with this in aim, we wanted to develop a multidisciplinary process that enhanced the core concepts of parental participation in caregiving and improving parent-infant interaction. So a little bit about our unit. The hospital as such and the unit opened in 2018. So we've just about completed 5 years of functioning. We are a relatively new unit, so we had no established pathways, policies, and guidelines, and we had to start everything from scratch. We are the only level 4 NICU in Qatar, and we are also a regional referral center. So we're dealing with the sickest of the sick infants in the region. Majority of times, our patient complexity and the acuity of the unit is very high. Most of the year, we are running over capacity. So when it's so busy in the unit, we all might have well come across this situation where the focus always shifts to acute care rather than developmental care practices. We have 54 cots, of them 42 are functioning, and we are fortunate that all these cots are exclusive single family rooms. As you can see in the picture, every room comes with a sofa cum bed for the parents to stay in. We are the only unit in the whole of the Middle East which has got an open family policy and an inclusive rounding policy. So we do give a lot of importance for parents being, for the quote we heard this morning, parents to be there for parenting. About our staff, we have a global and multicultural staff community with varied skills and expertise. And 5 years back, when we all came together to implement developmental care practices, because of the different practices these staff members were used to before, there was a lot of non-standardized care practices and inconsistency in care practices. Some came from units where family-centered practices were well established, and some came from units where they were not that well established. Also, majority of our staff speak English, whereas majority of our parents speak the local language, which is Arabic. So obviously, there were staff parent linguistic barriers, and although we do have a 24-hour interpreter service, still there was many an occasion where there was miscommunication and adequate information was not being conveyed. So all this had to be addressed. Our parents and families also come from a very multicultural and multinational background with a wide range of linguistic and socioeconomic backgrounds. So as staff implementing integrated family-centered developmental care, we had to be culturally sensitive, knowing their needs, and this was challenging to many of us as staff who are not used to these cultural differences. Parental involvement in our unit is very varied. A majority of the population of Qatar are expats, around 80%, and they're there for work purposes. So sometimes it's work and family commitments not letting them come into the unit. But for majority of our patients, they're still not aware of the concept of family-centered care. They don't know how to get involved in care. They don't know that involving in care is beneficial for their infant. And they're still very used to the traditional concept of caregiving where parents and where doctors and nurses are the sole caregivers and the baby belongs to the hospital. So given all these challenges, we took a stepwise approach. We first formed a core multidisciplinary team called the Family Integrated Care Group, and the group used the PDSA QI framework to initiate changes. With the gaps identified, we prioritized the known gaps and we started working on them. To improve parental communication, we sequentially introduced 3 different bedside family-centered tools. I'll come to all the tools one by one, and importantly, all these tools were adapted to the local language, which was Arabic. The first tool was every bedroom, every patient and every room, we installed a white big board, which was NICU tailored, and this board was to display all the information relevant to the parent, what the parent would want to know as he or she walked into the room. The titles of the sections were chosen to be in the baby's voice, in baby language, so it appeared like the baby is speaking to us. As you can see, in this one section for staff to leave messages, and there's some section for parents to leave messages. Sometimes we use it to post educational materials, resources, and flyers. In the care plan section, we try to just write what the major activity of the baby is for that week in layman's terms so that the parent can understand. This is one of the many creative boards done by our very dedicated and passionate nurses who spend a lot of time. And we've had really good feedback from the parents that they feel that the baby is speaking to them through the board, and it's some sort of emotional and comfort and relief for them, especially during stressful times on the NICU. The second family-centered care tool we had was the care team board. You can see it's a health card, a care team health card, which just tells them which doctor and nurse is looking after them that day, and when was the last update by a physician, so that any incoming physician comes and sees when the last update is, then they can fill the parents with whatever has happened with the baby thereafter from that date. Then we had another bedside tool, which is the train to home tool. This is a pictorial representation of the baby's journey from admission to discharge. Every baby before going home has to have achieved 6 milestones as the carriages of the train denote. And the progress is color-coded, so red, yellow, and green stickers. For example, if a baby is ventilated, the breathing gets red sticker. If the baby is on CPAP or non-invasive, gets a yellow sticker, and if it's ventilating, it gets a green sticker. So as the baby progresses to discharge, the parents will see more green stickers there. So then we also enrolled education to staff, and all staff in the unit received level 1 fine training in 2022 as formal training for neurodevelopmental care. Thank you to Monique and Stina for this. In the study phase, 1 year after the initiating of these initiatives, we did an initial audit just to see how effective our tools were. Unfortunately, out of 18 patients audited, only 3 of the patients were having their tools effectively updated by the staff members. So the reasons were staff were not having time, and also some of the staff were still unaware of these tools. So further looking into it, we felt that it was important to address this. So we went back and did planning phase, and then we did the do phase again. So with leadership support, we got protected time for staff educational sessions on different elements of IFCDC. And we also used huddles and WhatsApp groups for reminder messages to update the tools. Then we also introduced the bedside rounds, developmental care bedside rounds from last year, October 2023. So the core team went around once a week, and they met parents face to face. They talked to them about what family-centered care is, what are the benefits of parents as caregivers, and also staff were given bedsides, 1:1 education on many elements of IFCDC. So this was just some pictures from some developmental care rounds, a trolley with all the resources and some flashcards for teaching and our multidisciplinary team. We also then revamped our monthly parent support group meetings. This were happening from 2021, but not regularly, and there was not good attendance. So we ramped it with better attendance more regularly, and we used it as a platform not just for emotional and culturally sensitive support, but to deliver this education and to establish communication and rapport with parents. These are some pictures from our monthly group meetings. One is in the healing garden, one is inside the conference room. So further to this, we did another audit, again, 4 months after the implementation of these additional QIs, and the effective use of our bedside tools improved from 24% to 89%, which is a massive improvement. This is just the monthly data of the update of the boards. The orange bar chart shows the number of boards updated. We can see after the developmental rounds were initiated in October, there's a significant improvement of the effective use of the bedside tools. We also surveyed 14 inpatients, and we found that there was improved awareness of the benefits of IFCDC, improved awareness of the benefits of parental involvement in caregiving, and they were more aware of the tools, and they were more satisfied with the tools. Informal feedback we received from parents also concludes on this. The limitations of this study is the parent number we surveyed is small. The staff survey on looking at how staff feel about staff knowledge and how satisfied they feel about this is still ongoing. And also we are yet to look at the outcomes of how many parents are doing more work at the bedside and more involved in care of the baby. So as a conclusion, at this stage, I would like to conclude that the quality improvement initiatives have succeeded in improving parental staff communication, parental awareness of what IFCDC is, and how they can get involved in care giving, and there's been enhanced parental satisfaction of the family-centered tools. We are constantly trying to promote NIDCAP's policy. We're trying hard. We've got a long way to go, and work is still in progress, and we're looking at different ways and modes of improving this area of practice. I'll just share some of the references we used in this abstract. And before I come to the close of the presentation, I would like to thank everyone within our NICU, our leadership, and a special thanks to our division chief, Dr. Charlotte, our ex-division chief, and our senior attendings for the immense support, encouragement, and guidance they have been giving us. With that, I come to a close of the presentation. Thank you very much for your time and attention, and I welcome any questions and feedback.
Thank you very much, Sid. Is there any question from the audience? I have one. What is the single most important tool to keep the standards high, would you say? Or are they all equally important? You had a long range of things.
Sorry, can you repeat the question?
What is the most important thing to do to keep the standards high, to keep the results high over time?
I think it's consistency and love.
Consistency and love. Very good answer. Thank you very much. Unless there was any other question, no, I see no hands. Then we will welcome our next speaker, and that is Niklas Breindahl from Denmark, Rigshospitalet. Welcome. And please present your poster or your oral presentation. They were posters from the beginning.
Thank you, Fredrik. I think I can switch to the next slide myself. First of all, thank you to the organizing committee for accepting our abstract for presentation. As Fredrik just said, my name is Niklas Breindahl. I'm a medical doctor and PhD student at the Department of Neonatal Intensive Care at Rigshospitalet, Copenhagen in Denmark. I'm going to talk about our study called the Non-Pharmacological Approach, Less Invasive Surfactant Administration Trial, in short, the NONA-LISA trial. The purpose of my presentation today is to introduce you to our trial, but also to try and convince you to become a NONA-LISA trial site. So if you want to hear more about this, please contact me afterwards. This is a short video showing the LISA procedure in a preterm infant. It's recorded from the tip of the video laryngoscope. The LISA procedure is a way to administer surfactant intratracheally by use of a video laryngoscope and the catheter, as you saw in blue, to a spontaneously breathing infant supported by nasal CPAP or other non-invasive ventilation. and is indicated when the FiO2 is 30% or more and the CPAP pressure is 6 or above. Of course, this video only shows the technical aspects of LISA, and this is a problem because in order for the procedure to succeed, we need to focus on a lot of other factors than just the technical aspects of leading the laryngoscope. So when we talk about pre-procedure analgesia for LISA, we have a huge knowledge gap. Pre-procedure analgesia is associated with apnea and may also complicate procedures that rely on regular spontaneous breathing, such as the LISA procedure. We recently conducted a Delphi consensus study, which was published in 2023, among 153 experts from 14 different countries, actually to establish a curriculum and an assessment tool for the LISA procedure to try and determine when the operator is ready to advance from training in the simulation setting to the clinical setting. But we also asked them if they used pre-procedure analgesia, and this showed some quite interesting results. And as you can see, almost or more than 40% of the experts do not use any kind of pre-procedure analgesia in relation to the LISA procedure. On the other hand, non-pharmacological measures were used by almost 100% of the experts, and this included swaddling, wrapping, sucrose, and also facilitated tucking. But as I just said, there is a lack of high-quality evidence to support the beneficial or potential harmful effects of pre-procedure analgesia for the LISA procedure. Here you see the PQ questions for the NONA-LISA trial. So we include patients that are born at a NONA-LISA trial site before 30 gestational weeks, meeting the criteria for first choice surfactant treatment by LISA. The intervention group will receive isotonic saline, and the comparison will be fentanyl 0.5 to 1 microgram per kilogram, depending on the clinician's preference. It's very important to stress that both groups will receive a standardized non-pharmacological approach, which I will show you in just a few seconds. This will be individualized to the patient. And of course, as a safety parameter, we will allow for additional analgesics during the procedure as well, and this will be provided at the team's discretion. The primary outcome of interest is LISA failure, and this is defined by mechanical ventilation via an endotracheal tube for more than 30 minutes, cumulated within the first 24 hours after the procedure. According to our power calculation, we need 324 infants. I can go into the details afterwards. Now I want you to lean back and actually just enjoy the show, because I have a video demonstration of the non-pharmacological approach that we have developed for this trial. So afterwards, we will probably have a very interesting discussion.
Thank you for your interest in the non-pharmacological approach to the less invasive surfactant administration procedure. This video takes approximately 4 minutes. LISA stands for less invasive surfactant administration. It is a method of giving surfactant intratracheally to premature children with progressive respiratory distress syndrome and is indicated for FiO2 greater than 30% and CPAP pressure 6 and above. The team that performs the procedure consists of a doctor and 2 nurses. The doctor guides the video laryngoscope. It must be emphasized that the child's comfort and the possibility of completing the LISA procedure with little or no discomfort have the highest priority. Therefore, it is important that Nurse 1 continuously focuses on non-pharmacological measures and assesses the child's comfort NEO score. The nurse must verbalize the child's comfort along the way to guide the neonatologist on when the procedure can begin and when the procedure must be paused, or the speed changed. Nurse 2 is responsible for drug administration and assists with the procedure. Ensure the child is monitored, and do a team briefing before the procedure. The door is closed, the light is adjusted appropriately, people speak in soft voices, and the temperature is adjusted. When everyone is ready, the child is placed horizontally in a lateral position and swaddled. Nurse 1 supports the child's arms and legs in a flexed position close to the body. In this way, Nurse 1 can see and feel the child's breathing, body movements, and muscle tone as part of the comfort NEO score. If possible, cover the child's eyes. If the child can tolerate it, oral glucose or mother's milk is administered 2 minutes before the procedure. Subsequently, fentanyl is given intravenously at 0.5 micrograms per kilogram. Flush slowly with saline. Immediately before the procedure, the the child is carefully turned supine with slight back elevation. A quick ALPS-Neo score is made immediately before the procedure. The procedure can begin if the ALPS-Neo score is between 8 to 13 and the child has a sufficient respiratory drive. The neonatologist introduces the video laryngoscope into the child's mouth and visualizes the trachea. The laryngoscopy can be uncomfortable for the child, so it is essential to handle the laryngoscope gently. Remember that the child's comfort and the possibility of completing the LISA procedure with little or no discomfort have the highest priority. After the procedure, the neonatologist carefully removes the video laryngoscope and maintains the position of the catheter while closing the child's mouth. Nurse 2 administers surfactant slowly in collaboration with Nurse 1, who assesses and articulates the child's respiratory drive. Finally, Nurse 2 flushes the tube with air, while Nurse 1 stimulates the child's breathing, if necessary. If the ALPS-Neo score at any time is above 13, the team must improve non-pharmacological measures. If this is insufficient, additional fentanyl can be administered. Once surfactant is being administered, the catheter should remain in the trachea. However, the rate of administration may be slowed, or the administration may be briefly paused if the child's respiratory drive is inadequate. Managing complications during the procedure, such as bradycardia, desaturation, and surfactant reflux, is important. Pause the procedure and stimulate the child's breathing. Consider increasing the FiO2 and checking that the SWEpap is appropriately connected. Finally, the neonatologist carefully removes the surfactant catheter. After the procedure, the child is gently placed in a lateral position to support the child's breathing. The child is supported until the child is once again calm. Thank you for your attention.
I think my time is up, so I just want to say thank you so much for your attention. Please feel free to access the QR code and you will have a direct access to the protocol article, which was recently published.
Thank you very much. I'm certain there are questions in the audience to Niklas. If there aren't any, I will proceed with one. Have you included any patients yet?
Yeah, so currently we are in the pilot phase of the NONA-LISA trial. It's very important for us to implement this study in the right way. So we are currently including in the pilot study at Rigshospitalet. And we have included 12 patients, and we're collecting feedback as well from the team doing this procedure.
Thank you very much, Niklas. What response do you get from the parents when you present the study?
That's a very good question. And actually, in Denmark, this study was approved for deferred consent. And for those of you who don't know what deferred consent is, that this means that the child is randomized and included before we ask the parents for consent. And then afterwards, we, of course, get their consent if they want to consent, and they stay in the trial, but there will be no more interventions. Yeah. So in that way, we don't tell the parents before we actually enroll them in the study. Yeah.
There is one more question here.
Thank you. Great, great video. I will restrict to one question. How will you teach the teams to do this properly? Because this was with a mannequin, was not with a real child. So how does your instruction program looks like, and when do you consider them as having reached expertise level in this, so that you can count on a kind of standardized surrounding?
Thank you very much for that question. I think that's very important. In Denmark, well, at least at Rigshospitalet, there has been actually no formal training for either the doctors or the nurses, but we do this procedure routinely. What we do now, from now on, once we have developed the LISA assessment tool, which I just showed you in the previous publication, is that we will start educating the staff using this tool to assess their level of competence. We're just in the process of writing a manuscript that actually validates the LISA assessment tool for being used in LISA training. Yeah.
Thank you, Niklas. we saw in the video that the nurse was stimulating the baby's breathing, the baby to breathe. Would you comment on that?
Yes. I'm not quite sure what you mean by commenting, but yes, she is stimulating the child's breathing. And this is because we have seen, at least in the pilot study, and these are preliminary data, but we have seen that giving either fentanyl or saline, it's pretty obvious that, of course, this is a blinded intervention, but when they guess that they have been given fentanyl, this is associated with apnea as well with the child. So it's very important for us to try and stimulate, to try and see if we can make them breathe spontaneously, because this is a kind of a fundamental thing for the LISA procedure to actually succeed.
Do you think, or do you think that babies also stop breathing when they are in pain?
Yes.
So it might be very difficult to know the reason for this, I think.
Yeah.
Maybe.
Yeah. So
do you put that in your protocol if you need to, if the baby actually has a pause in the breathing?
Yeah. So we will intra-procedural assess if they have any kind of complications in terms of apnea, also bradycardia, desaturation, but apnea will be part of this. Yeah. And then we assess the ALPS-Neo score, the highest ALPS-Neo score during the procedure, and try and mark whether it's during the laryngoscopy or the catheterization or the surfactant administration to try and see if this correlates to the high ALPS-Neo score. Yeah.
You got many questions, and there's still one more.
I'll just, my name is Ponti. I'm part of this pilot study. I've also enrolled some patients. So just a comment on Stina's comment. Of course, we stimulate when they do the apnea, but we don't know if it's because of the fentanyl or the procedure. Mm. But we are allowed to guess. We will write on the comment paper what we think the child got, saline or fentanyl. We don't know. You have to do the analysis afterwards. And of course, there's a limitation in the new comfort score, because if they're like unconscious because of fentanyl or pain, they will score low. Yeah, but it will be in the discussion. And a comment on the training on the pilot. We agreed on a center that in the beginning of the study, we will always be 2 senior doctors at the procedure. So we support each other. The one do the procedure, and the other just be aware of the surroundings. Then just support each other and say, now I think you should pause or do something else. And also be aware of the parents, because it's difficult to be aware of everything and do the procedure. Yeah.
Oh, there are more hands in there. I will have to omit my more questions.
Hi, my name is Kenny. I'm a relatively new nurse here at the NICU in Lund. I was just curious, in the video there are 2 nurses and a doctor, but given the theme of, or a lot of the themes today, involving parents in the procedure, is this something you've kept in mind? Because one of the nurses is doing the Neo score thing. Could that nurse stand on the side and do that, and the parent could instead be involved?
So because of the child is being wrapped, it's very important that the nurse has her or his hands on the infant. And this is basically to feel any kind of movement below the blanket. I know the ALPS-Neo score has a lot of limitations, and especially when we try to apply it intra-procedure, which it was not developed for. But yeah, so the nurse needs to keep the hands on the infant. Of course, the parents should stay close, but this is not a part of the protocol, so they don't have an active part to play during the procedure.
Okay, thank you.
Yeah, thank you very much, Niklas.
Thank you.
And now it's time for Bente Johanne Vederhus from Norway. Welcome.
Thank you for the organizing committee for letting me present our study, a validation study of ALPS-Neo. Yeah, the ALPS-Neo, this is a pain and stress assessment scale for preterm and sick newborn infants, developed in Lund and Astrid Lindgren Children's Hospital. The study was published in Acta Pediatrica in January last year. First, a brief introduction to our history of pain assessment in our 3-level unit NICU at Haukeland University Hospital in Bergen, Norway. We have approximately 450 infants admitted to our unit each year. In 2006, we implemented premature infant pain profile, the PIP, as a pain assessment tool in our unit after having translated it into Norwegian and thereafter validated it. PIP is a multidimensional measure for pain, as most of you know, and as Maria also pointed out to you, and one of the most used observational tools in pain research, and the psychometric properties has been extensively tested. However, the implementation of PIP was without success. The nurses experienced it difficult to administer. So, at the conference in Ålesund in 2008, also Ålesund in Norway, we were introduced to ALPS-Neo by Agneta Kleberg, and defining our unit as a NIDCAP unit with several NIDCAP observers, we decided to implement ALPS-Neo as the tool for pain assessment. So, and I would say, with success, we have implemented it. Pain assessment is performed regularly, treated as the 5th vital parameter, still 9 years after implementation. ALPS-Neo is unidimensional and has 5 behavioral indicators scored and summed up to a total of maximum 10 points. This was actually the next slide, too early. From the very beginning, we intended to validate ALPS-Neo further. To our knowledge, only one study demonstrating its psychometric properties has been published. We were applying it in various situations, pain situations, even though it had been developed for continuous pain and stress assessment. We aimed to investigate if it was applicable as a measure for procedural pain with the following 3 aims: to investigate interrater reliability, construct, and criterion validity. We used a repeated measure design with a convenience sample of 55 infants based on power calculation. Both preterm and term infants were included. We had a setup with video recording of the infant's routine blood sampling. We were recording 3 events in relation to blood sampling procedure: a baseline when the child was at rest, wiping of the skin, which represented a non-pain event, and thereafter the heel stick being the pain event. Standard care during the procedures were followed, that is pacifier if preferred by the child, positioning support by a parent or a nurse, and administering of sucrose 2 minutes before the heel stick. You can see our research lab here on the photo. It made it possible to record simultaneously with 4 cameras, the heart rate, oxygen saturation, skin conductance, and the face and the body of the neonate. The arrangement with the infant, that is establishing the monitoring, was done in due time before the sampling procedure, so the child was at rest. Of the 55 included infants, 1 was excluded in the analysis due to low data quality. 4 expert nurses performed the assessments of the 3 events. Values for all the 3 events were assessed within 30 seconds following the baseline, the non-pain event, and the pain event. 2 of the nurses assessed independently 21 randomly selected video recordings to establish interrater reliability during the 3 events. One of these nurses, being a NIDCAP observer, assessed further all the videos to score ALPS-Neo during the events. Another nurse assessed all the video to score the PIP revised, which was used as the primary criterion for the criterion validity, and the fourth nurse assessed all the videos to record the maximum response of the skin conductance, peaks per second, which was the second criterion. The characteristics of the included infants are seen here in Table 1. The mean gestational age was nearly 34 weeks, and mean age as assessment was nearly 13 days. Only a few of insert had any respiratory support, that is some sort of oxygen supply here. Concerning the inter-rater reliability, statistically significant results were obtained during the skin wiping and the heel stick event, seen here in Table 2 in bold values. When it comes to construct validity, ALPS-Neo did demonstrate ability to discriminate between pain and non-pain events, seen in bold values in Table 3 here. Concerning the criterion validity, ALPS-Neo correlated acceptable with the primary criterion, which was PIP-R values during the pain event, a correlation coefficient of 0.56. However, it did not correlate with the values of the skin conductance algesimeter. In conclusion, ALPS-Neo may be used also as a measure for procedural pain in preterm and sick-term infants, making it possible to apply only one observational tool for both continuous and procedural pain in the neonatal care units. So, thank you for listening.
Thank you very much. Are there any questions?
Thank you. In the validation study, did you look at learning curves to try and see how much time it takes to train people to actually assess pain using the ALPS-Neo score?
No,
no,
we didn't. No, that wasn't part of the trial. It was just sort of validated, and not any training sessions for the scale. No.
Because I think that would be quite interesting to see. I know there are a lot of pain scores around the world. In Denmark, we use the COMFORT-Neo score, and one of the reasons that we use it for our trial is that we already use it.
Yes.
So it's feasible. Yeah. So if it takes a lot of time to practice, then it would be nice to know whether you should go on and continue with that.
I think it's the most important about pain assessment is that you actually do pain assessment at the user tool, because as you say, there are several tools developed, and you don't know actually for some of them if they actually measure pain. But so you have to continue this validation procedure, the psychometric properties.
Any more questions? I have one more. What, in your opinion, is the reason why the skin conductance didn't correlate with the scoring?
We don't actually know, because the developer of the skin conductance algorithm, Hanne Storm, she was a part of the study, and she didn't understand either. But we were discussing it in our paper, why it didn't correlate, as we hypothesized, but it was a second criterion. And the first criterion was the PIP, which also is an observational tool. And this skin conductance is a response, is a physiological response, and maybe it's measuring pain in a different way. So it didn't correlate, and I can't say actually why.
Okay. Then we thank you very much.
Okay, thank you.
Yeah.